Good evening, everyone. This is the first session in our planned teaching series. So we'll be talking about ECG, basics, blocks, and bradyarrhythmias. So we'll be looking at some of the basics of ECG. So this is not an extensive class. This will guide you to see an ECG and just the basic approach how to look at it. The JRs, we would actually be confused when we see an ECG. Say some M or W is there. It's a bundle branch, but we'll directly go to that. We don't actually see what's there in ECG as a whole. We don't see the rate, rhythm, and stuff. So it's like a basic approach how to proceed with an ECG. And we'll also be seeing about the different types of blocks, and we'll also touch upon bradycardia algorithm. So ECG or EKG stands for electrocardiogram. It depicts the electrical activity of the heart. In the upcoming slides, we will see how this electrical activity is actually converted into the ECG paper. So like our radiologist friends say, we should clinically correlate it. We should treat the person or not the ECG per se. The main uses of ECG will come into play when you are looking into the rhythm abnormalities and infarctions and ischemia. So this is the ECG, a little bit of physics here. So it's all about the vectors. At resting state, the inside of a cell will be negatively charged. The outside will be positively charged. When a cell is getting depolarized, the opposite happens. The inside of the cell becomes more positive and the outside becomes more negative. So this positive charge, say there are electrodes, negative electrode and positive electrode, this positive charge will move towards the positive electrode. If that happens, there will be a positive deflection in the ECG curve. If the opposite happens, say the positive charge move towards the negative electrode, there will be negative deflection in the ECG. And there are 12 leads in an ECG. 6 of them are called standard leads. The other 6 are called the chest leads. These standard leads help us to look at the heart from a vertical or coronal plane, whereas the chest leads will give the horizontal or transverse plane. The chest leads are named from V1 through V6, and the standard leads are named leads 1, 2, 3, AVR, AVL, and AVF. We need not look like how these leads are made, but we would have to know how these what it represents for. See the first lead, it originates from the right arm to the left arm. The negative electrode is the right arm. The positive electrode is the left arm. For lead 3, the left arm becomes negative and the lower limb becomes positive. And for lead 2, the right arm becomes negative and the left arm becomes positive. So it will be the electrode will be the lead will be facing from here, and the second lead will be coming from the right atrium to the left atrium. This all becomes important when you see the try to correlate the area of the heart with the lead. And AVR in the AVR stands for augmented leads. It means that when you take an average of all the right arm, left arm, and the left leg, you will reach the center of the heart. So from there, if you look at the right arm, that is the AVR lead. If you look at the left arm, that is the AVL lead. And if you look at the feet, that is the AVF lead. When connecting the leads, we will also be placing on right lower limb electrode. Usually it acts as a neutral lead, so it doesn't actually contribute to anything. We should also be aware of the placement of the lead. So we shouldn't misinterpret exchange leads as say dextrocardia or something. So we should be careful with the placement of the leads. A little bit of anatomy here. So the two main coronary arteries, the right coronary artery supplies the inferior surface of the heart. The left coronary artery divides into the left anterior descending artery and left circumflex artery. This right coronary artery, as I said, it supplies the inferior surface. This anterior descending artery supplies the septal as well as the anterior region. The circumflex artery supplies the lateral surface of the heart. Why this becomes important is if there is an infarction or ischemia, this will translate into the respective leads. So you can correlate the leads with the area of the heart that is involved. So in this diagram, you can see that the leads 2, 3 AVF look at the inferior surface of the heart. This corresponds to the right coronary artery. The leads 1 AVL as well as V5, V6 look at the lateral surface of the heart. that corresponds to the lateral circumflex artery. And the anterior or septal leads are the V1, V2, V3, V4. This corresponds to the left anterior descending artery. And another thing to note is that compared to all other leads, the lead AVR is placed opposite to every other lead. So the P wave will be negative there. The T wave will also be negative there. You should focus on that. And the general orientation of the heart, there is the cardiac axis lies towards the lead 2. Even before interpreting an ECG, you should look at two things. One is the speed of the ECG paper. The standard speed is set at 25 millimeter per second. Say if the speed is reduced to 12.5 millimeter per second, the paper will be moving slow. But the ECG, the caliper will be moving at its own speed. So you will get an ECG recording where everything will be bunched up together. And the same happens if you increase the speed of the ECG, the paper will be moving fast, the caliper will be moving at its own speed. So you will be looking at an ECG which is very spaced out. And another thing, which you will notice at the start of every recording is the calibration. So for 1 millivolt of amplitude, you will get a deflection of 1 centimeter. This 1 centimeter is 2 large boxes. So if there is a deflection of say 2 centimeter per 1 millivolt, then you will get an ECG which you can interpret as an hypertrophied heart. And if it's very less, say the deflection is less, then you will get an ECG which you can misinterpret as pericardial effusion is there. So you should be aware of these two things even before you go into the ECG. And looking at the standard ECG paper, one small square corresponds to 0.04 second, and one large square contains 5 small squares. So if you just multiply, it is 0.2 seconds. These calculations stem from the point that the ECG paper is set at a standard of 25 millimeter per second. So if the speed is different, this whole thing will change. So you should make sure that it's in 25 millimeters per second. And the vertical axis is the amplitude of the ECG wave. It corresponds to 2 large boxes will correspond to 1 centimeter. And the different waves which are seen in the ECG are named PQ, RS, T, and U. These are taken at random, like these doesn't, people just arbitrarily chose these letters starting from PQ, RS, T. The P wave corresponds to the atrial depolarization. The QRS complex corresponds to the ventricular depolarization. The T wave is the ventricular repolarization. The atrial repolarization we can't see here because it would be lost in this ventricular repolarization thing. This U wave, if it follows a normal T wave, that can also be considered as normal. There is no common consensus, but people agree that it is due to papillary muscle repolarization. It won't be very much important, but say if the T wave is inverted and it's abnormal and you see a U wave, that could be a feature of hypokalemia. The intervals we will see in the upcoming slides. So the different interferences which can affect an ECG reading would be shivering, tremors, sweating, and electrical interferences. If the patient has a condition in which he has tremors, the ECG may not be readable. You can misinterpret as something else. And if there are any electrical interferences, the ECG baseline will be very thick. And if the patient is sweating, there won't be proper contact between the leads and the patient's chest. So that will also cause an interference. So that's about the basics. Now we'll see how to approach an ECG. So you can remember this mnemonic REACT. I would like to take a moment to thank Dr. Ria for lending her name. Okay, it's just so this is just to help you remember. R stands for rate and rhythm. I is the interval. A is the cardiac axis. C is the QRS complex, and the wave. T is the T and ST waves. Sorry for the disturbance. So as I was telling, to calculate the rate, you should count the number of large boxes. We should count the number of large boxes and divide the number 300 by it. And for more accurate thing, you can count the number of small boxes and divide 1500 by it. So if the rhythm is irregular, then you can't use this formula. Then you can just look at the rhythm strip. Most probably it will be the lead 2. You can count the number of QRS complexes in it, and you can multiply it by 6. Then you will get the rate. Coming to the rhythm, the normal rhythm is called the sinus rhythm. It gets its name from the SA node, which gives it a rhythm. When you compare to other muscles, heart differs from other muscles in that it has something called automaticity. These SA nodes fire on their own. So for you to tell us a rhythm is normal or sinus, for each P you should have one QRS complex, and the rhythm should be regular, and all the waves, intervals, and rate, it should be normal. So it's like you should go through the ECG, and then you can come back and tell that it's in sinus rhythm. Coming to the intervals, the PR interval, so people usually confuse between the intervals and the segments. You can remember it by telling that the segments secludes the waves, whereas the interval includes the waves. The PR interval includes the P wave, and it starts before the P wave till the end of the QRS complex. This PR interval, it's actually the spread of the electrical excitation from the SCA node to the atrial muscles to the AV node to the bundle of His to the ventricular muscle. It should usually be less than between 120 to 220 milliseconds, or 3 to 5 small boxes. The QRS complex, it should be less than 120 milliseconds or less than 3 small squares. The QRS complex corresponds to the ventricular depolarization. When you add up the ventricular depolarization and repolarization, you will arrive at the QT interval. So the QT interval, it varies with the heart rate. So for standardization, people have used many different formulas. One such formula is the Besset's formula, where you divide the QT divided by the square root of RR interval. Then you will arrive at the corrected QT interval. Most of the ECGs will give this corrected QT interval, but you should take it with a pinch of salt. So in men, it should be less than 450 milliseconds, whereas in women, it will be less than 470 milliseconds. The common problems where this might be helpful is calcium actually helps to help for contraction. So if there is hypercalcemia, the QT will be shortened, and if there is hypocalcemia, the QT will be widened. And some other drugs which cause QT prolongation are the antipsychotics and antidepressants. Even macrolides cause QT prolongation. How to calculate, how to arrive at the cardiac axis? There are different methods by which you can determine the axis. Two simple methods would be the thumb rule. In the thumb rule, for lead 1, you can get your one thumb like thumbs up. If it's predominantly positive, you can take it as thumbs up. Then you can look at the lead 2 or lead AVF. Either of the leads you can look. Say if the lead 2 is also positive, since both the thumbs are positive, it's a normal axis. Say if lead 1 is positive, that is thumbs up, and lead 2 is negative, that is thumbs down. The thumbs will be leaving each other. If it leaves each other, it is in left axis deviation. The opposite, if the lead 1 is predominantly negative, that is thumbs down, lead 2 is predominantly positive, that is thumbs up, the thumbs will be facing each other, that is reaching each other. So you can remember the right axis deviation. The another method would be looking at all three leads, lead 1, 2, 3. See in this diagram, if you look, if all the three leads are positive, say leads 1, 2, and 3, the axis should point in this direction. The cumulative axis should point in this direction. If lead 1 is predominantly negative and lead 2 and 3 are positive, so if lead 1 is negative, it should be away from lead 1. These two are positive. So the axis will swing towards this side, that is right axis deviation. Say if lead 3 is negative and it's predominantly positive in lead 2 and 1, the axis will swing towards the lead 1. It will be left axis deviation. So you shouldn't just fix on one method to look at the axis. Sometimes you might end up in trouble. So you can remember two of these things. For accurate representation, you can calculate the degrees, but it's an for time being, like I'm not going into it. So at the end, you will be arriving at if it's a right axis deviation or left axis deviation. This deviation, they themselves don't mean anything. So say if a patient is very obese, the heart, due to the obesity and his heart might be pushed up, the diaphragm might be pushed up. In that case, you might see left axis deviation. The opposite, if the person is very thin, you can see right axis deviation also. Coming into the QRS complex and the Q wave. For you to tell something as a normal QRS complex, it should be less than 120 millisecond or less than 3 small squares. And also you should look at the chest leads. In the chest leads, you can study the QRS morphology. These, you have to remember some rules regarding the QRS complex. The lead always gets depolarized from the left side to the right side. And the left ventricle, due to its mass, it exerts more influence on the QRS complex. These two things you should keep in mind. So if you look at the lead V1, if it's in the left, the leads V1 and V2 look at the heart from the right ventricle. V3, V4 correspond to the septum. V5, V6 look at the left ventricle. So if you look at the V1, the septum depolarizes from the left to right. So it's moving towards V1. Then in the normal QRS complex, you would find an R wave. Then since the left axis, since the left ventricle exerts more influence, this thing will be moving away from the, this vector will be moving away from the V1. In that case, you will find an S wave. The opposite happens in the V6, where the septum will be depolarizing away from the V6 and the whole of the left ventricle will be depolarized towards the V6. So you will get a negative Q axis, Q wave and a positive R wave followed by it. What is the abnormal Q wave? For simple purpose, you can remember that if a Q wave is more than one small square in diameter and more than one small square in depth, you can consider it as abnormal. So why these abnormal Q waves are found? The heart is a closed chamber. All these leads look the heart from the surface. But say if a patient has a myocardial infarction, then this part of the heart will create a window. So the lead which is on top of that specific segment will actually be looking at the heart from inside. The lead will be inside the heart. So say in here the V6 part, there is a myocardial infarction you consider. This creates a window. So the lead V6 will look the heart from inside. So in that lead, whatever vector, it will be moving away from, it will obviously moving away from the inside of the heart. So you will get a negative deflection. That is the abnormal Q wave. But one catch is that you can't tell the age of the infarction from these Q waves. Even old infarctions will produce these Q waves. Coming to the T wave is a repolarization of the ventricle. So if it's inverted, it means that the repolarization didn't happen how it actually happens. So in even in some these inversions, you should consider in contiguous leads. Contiguous leads are the leads 2, 3 AVF would be contiguous. 1 AVL V5 V6 would be contiguous, and leads V1, V2, V3, V4 would be contiguous. So if the inversion is there, you should look at all these leads. Then only it will give you an idea of what's happening. So in all these conditions, T wave inversions can be seen in normal people, ischemia or infarction, ventricular hypertrophy. In bundle branch blocks, you will see these T wave inversions. And in some other conditions where T wave will become abnormal is that in hyperkalemia, there will be peak T waves. In hypokalemia, T wave inversions will be there. You can remember by thinking that someone is pulling up the T wave up in hyperkalemia, whereas in hypokalemia, the T wave is pushed downwards. In hypomagnesemia and hypermagnesemia, it will be similar findings can also be seen. This QRS complex is the ventricular depolarization. It doesn't correspond to the ventricular contraction. The actual muscle contraction occurs after the depolarization. So that the ventricular muscle contraction is the ST segment. It happens in the ST segment. The ST segment, it should be isoelectric. That is, it should lie at the same level as the line between the T wave and the next P wave. Say if the wave is getting depressed, there are two types and downslope depression. In upslope depression, there will be, whereas in downslope depression, you can see it in digoxin treatment as well as digoxin toxicity. So if say if normally the ST depressions are not seen, but it's seen only during exercise, then it could be due to angina. ST elevation, if the ST elevation is widespread, it will be seen in pericarditis. But if it is in that contiguous leads, like I told, it corresponds to the infarction in that specific region. We'll be looking up at the ST in detail in the next session. For completion sake, we'll also look at the P wave. A normal P wave should be less than 2.5 small boxes in height and as well as less than 2.5 small boxes in width. It will be positive in leads 1 and 2. Like I told, AVR is actually facing away from all other leads. So P wave will also be negative in it. In right atrial enlargement, the amplitude of the P wave will be increased. It's also called P pulmonale. In left atrial enlargement, there will be bifid P waves because the left atrium is getting enlarged. It will create a specific impression on its own. So we will see a bifid wave. It is also called P mitral. So that is all about the basics and how to approach an ECG. We'll be seeing 3 ECGs next. I need a volunteer like who can tell if it's normal or abnormal. If it's normal, you have to just tell what are things, the rate, rhythm and stuff. I'll give a chocolate if you tell correctly. Yeah. Volunteer. Please make it quick. Anyone? I'll help you with it. How?
Rate is
300 by 300, around 100. Okay.
Then rhythm is sinusoidal.
Okay.
Then
interval PR interval 1, 2, 3, 4. 4 boxes are there. Normal. The QRS complex, it is also 2 boxes are there.
Then axis.
Just look at leads 1 and 2. So it's a normal axis. Look at the chest leads, the QRS complex.
No.
Normal. Do you have any abnormal Q waves? The Q waves are like very big and stuff. Any ST depression? elevation or T wave inversions. There is a T wave inversion is here. You want?
That is normal.
Flattening is like AVN. We are not able to see the TV. Flattening can be like it is a conjugated. That's what he wants to stress. Single TV emotion cannot be taken as single TV. It should be conjugated.
Okay. So it's a normal ECG. Chocolate. So is this normal or abnormal? What is the abnormality? You need not like tell the diagnosis per se, but what is it? Two chocolates. Just follow that react. Like I told you, should not jump into the interpretation. Just still like R. The rate is normal, like 100, around 100. Rhythm. The PR interval is prolonged. The QRS is also prolonged. And there are widespread T wave inversions. There are no ST depressions or elevations. And also here, the R wave progression is not there in the chest leads. That what we saw, the usual QRS complex is not there in the chest leads. So this is abnormal. We'll look into what's the abnormality here. So this is a case. Patient called Mr. Benjamin. He's 76 years old. He presented to the OPD. His heart rate is 86 per minute. BP is normal, 120 per 86 per 86 mmHg. He doesn't have any complaints, but when you take his ECG, you are seeing this. And on general examination, he doesn't have any reaction on his face, and he gives a history that he falls frequently. 76 years old gentleman. He's a known case of hypertensive, but he's on antihypertensives. He is complained in that, and his heart rate is 86 per minute. BP is normal. It's just a general regular checkup. He had come for a general checkup. On taking the ECG, you see this. And on further questioning, he also gives a history that he has frequent falls. And you see that he doesn't react much to whatever you tell or whatever happens. And on further questioning, he also tells that his doctor had prescribed him a medicine for something, but he's not complained on it. What is this ECG?
Not compliant in the sense.
He's not taking a medication for. What is this ECG? Okay, the emergency doctors suspect that some ventricular tachy is there. They gave amiodarone. It's not settling. He's normal. No such abnormal. No electrolyte abnormalities.
Any previous ECGs
We are not aware of.
was he having any QT prolongation before?
No.
QT was every time.
He's not taking any other drugs, QT prolongation drugs or anything. Focus on the history. He doesn't remember. The history is he has frequent falls and he doesn't react much. Like whatever we tell, he also slowly reacts. Slow reaction timing is there. Do you want any other clue?
No, some Parkinson is there.
Okay. The patient has Parkinson. This is Parkinson tremor. So due to the tremor, the ECG is looking like a VT. Then the cardiologists were called for the case, and even after giving amiodarone and stuff, it's not settling. Then on further questioning, he had Parkinson's. So due to the Parkinson tremor, the ECG is reading like it. So you should also consider all the history and stuff before commenting on what the ECG is. But this
He told the shivering also can like
the DCG interferences we were talking. This is the last section of the topic. We'll be looking into the blocks and bradyarrhythmias. So you should remember this wiring diagram of the heart. So the electrical activity starts at the sinus node. It spreads to the atrial muscles. It reaches the AV node. Through the bundle of this, it travels to the right bundle and the left bundle. When we initially saw how the usual QRS complex forms, similar to this in right bundle branch block, you can remember it as a marrow. It's a mnemonic. You will see M pattern in V1 and W pattern in V6. Now we will see how this pattern is formed. So here the right bundle is bundle branch block is there, but the septum depolarizes normally. So you will get a positive deflection R. Then the left ventricle gets depolarized. Since it's away from V1, you will see a negative deflection, that is yes. Then at last, the right ventricle depolarizes one way or the other. Then it is facing towards V1. Then you will get another positive deflection. Then that's how you get the M pattern. The opposite thing happens in V6. In left bundle branch block, you can remember this by remembering this mnemonic William. So in V1 you will see W, and in V6 you will see M pattern. This is also similar. So here in left bundle branch block is there. So usually the septum depolarizes from left to right. But since here the left bundle branch block is there, the septum will be depolarized from right to left. So in V1 you will get a negative deflection. The septum is getting depolarized from right to left, opposite to the V1. So it will get a negative deflection. Then since the left bundle branch block is there, the right ventricle depolarizes first. It produces small positive deflection. Then at last, invariably, the left ventricle also gets depolarized. Since it's away from V1, you will get a negative deflection which goes up. This is the S wave. So that's how this W is formed. Similar to this, in V6 you will see M. This is about the right bundle branch. There are also anterior and posterior fascicles, but you can go up and read on it. It's not like needed right now. We'll see the various degrees of heart block. 3 degrees of heart block are there. 1, 2, and 3. In 1, there will be prolonged PR interval. In 2, 2 types are there. In the first type, the PR interval gets prolonged gradually, and then at a time, there will be a non-conduction of the beat. In type 2, PR prolongation will be there, but each beat will be conducted normally, and at one point, suddenly, there will be a non-conducted beat. In third degree, it's completely random. The P wave follows its own pattern. The QRS will follow its own schedule. So there will be complete dissociation between these two waves. So you can remember this by following this analogy where the P wave is the wife and the QRS is the husband. So say they are recently getting married, they are in sinus rhythm, they are very much amicable. So for each P wave, the QRS will be there and it will be normal. In the first degree, they have some problem in between them. So the QRS will be late, the PR will be prolonged, but it will be fixed. In second degree type 1, the husband progressively comes late to the home. At a point, he completely stops coming suddenly. That will be type 1. In type 2, it seems that apparently everything is all right, but suddenly he stops coming. That's not type 2. In third degree, they are like separated in their marriage and they have their own individual schedules. People tell that this type, see, one is like apparently normal, and then suddenly something happens, it should be abnormal, right? So type 2 and third degree are considered, say, if you in a bradycardia algorithm, if you find type 2 and third degree heart block, you would be treating with atropine. So this is the bradycardia algorithm. It's similar to the American Heart Association guideline, but this is a RSS UK guidelines. If the patient is having bradycardia, so the 3 types of algorithms are there in this RSS UK: bradycardia algorithm, tachycardia algorithm, and cardiac arrest algorithm. In bradycardia and tachycardia, instead of this, as opposing to the cardiac arrest, you will first see this ABCDE, the airway, breathing, circulation, disability, and exposure. Everything is normal, we'll see. Then monitoring, we should start the ECG monitoring, BP and the saturation. And we should also treat any electrolyte abnormalities are there. And if there are any life-threatening signs are there, shock, syncope, myocardial ischemia or heart failure. If these life-threatening signs are there, we will begin by giving 0.5 mg of atropine. If the satisfactory response is there, or if no life-threatening signs are there, patient is apparently all right, then we will look into his history if there is any history of recent asystole, because there will be more chances of him going into asystole again. And we'll look at the ECG by this time. If there is a type 2 heart block, or if there is a type 2 heart block or a complete heart block, then also we should be giving 0.5 mg of atropine. See, why this looking for reversible causes become important is that, say, if the patient is having hypokalemia and he gets brady, if you give atropine, it won't settle. You have to treat the hypokalemia. Only then the bradycardia will settle. So that's how this electrolyte abnormality comes into play. So in this, what will you do? What is this ECG and what will you do in this situation? The P wave is following its own pattern. The QRS is following its own pattern. Atropine, we should, this is complete third degree heart block. So we should begin by giving atropine, and for further thing, we will do pacing. So that's the end of the session. Just a minute. So we saw how the normal R and S are formed. Usually the septum depolarizes from the left to right. When you look from V1, since the septum is from left to right, the V1 is the right ventricle, right. So it's moving towards V1. Then you will get a positive deflection is R. Then the whole of the ventricle, more influence is exerted by the left ventricle. It's moving away from the V1. Then you will get a negative deflection in V1. That will be R and S. That is how normal thing happens. In right bundle branch block, the right bundle, you can consider the right bundle as absent. The septum will be depolarized as normal, because for the septal depolarization, it is contributed by the left bundle branch actually. So it will be depolarized from the left to right. You will see the normal R. Then the left ventricle depolarizes first. You will get a negative deflection. It is moving away from V1. Even though the right bundle is not there to supply the right ventricle, the right ventricle gets depolarized later from other parts. So invariably you will get right ventricle depolarization at last. So it is moving towards V1. It will also be positive. That's how you get the another positive wave. The other positive wave is called R prime. That is the M pattern. Opposite to this happens in the V6. Like if you invert M, you will get a W pattern. The same thing happens in left bundle branch block. The left bundle branch you can consider as absent. So since the septum is septal depolarization is contributed by the left bundle, the septum can't depolarize in its normal way. So the right bundle contributes to the septal depolarization. But since the right bundle is contributing, the septum depolarizes from the right to left. When you look from V1, it is away from right. So you will get a negative deflection instead of the usual positive deflection in septal depolarization. Then since the right bundle is there, the right ventricle gets depolarized first. And even though the left bundle is not there, invariably it has to get depolarized. So at last the left ventricle also gets depolarized. It is away from V1. You will get the negative. So it forms the W pattern, and the opposite to this happens in the V6. Any other questions?
The common T-wave abnormality is that
in right atrial enlargement, the amplitude of the P wave will be increased. In left atrial enlargement, since the second part of the P wave is contributed by the left atrium, we'll see a bifid P wave. So for For practical purposes, you can consider as a 2.5 small boxes height, 2.5 small boxes width. That is a normal P wave. In atrial fibrillation, the fibrillation means that the heart it's not contracting properly, so we won't be able to see the P waves as such.